he has been a member of several societies, including the Cardiological Society, the API, the Geriatric Society, and the Critical Care Society. And he has been professor of geriatrics and internal medicine too. And he has been author of several chapters in various textbooks of medicine and updates of API, CSI, and Geriatric Society of India. With this introduction, I'd let Dr. Jayantha Sharma take over, and his topic will be clinical approach to a patient with heart failure. Dr. Sharma.
Am I audible?
Yeah, you are audible.
Yeah. Thank you, sir. Thank you for your kind introduction, because you are pioneer in critical care field since we have been joined in this medical science basically. When we have been returned back to Calcutta, Susruta sir was our boss as well as our head, who has been brought us in this critical care field whenever we have been started our critical care practice in Calcutta city. Since last more than 25 years, we are working together in the same hospital, same city, and we are attached to the different hospitals. Sir has requested me to talk on the topic for all of us today in this Society of Critical Care Nursing Society, the clinical approach to heart failure in the elderly patients whenever the patients are entering in our ICU or in the hospital or in the emergency department. So this is a very nice topic, and because in the ICU setup and these things, one of the very common presentation for the elderly patients is a heart failure. In general, not only the heart failure, patient usually presents with the symptom of breathlessness, SOB. So if a patient of elderly patients after the age of 60 years or above that present with SOB or patient is having a respiratory failure, one of the diagnoses usually having the heart failure. So for a nursing point of view, not only the nursing point of view, for the medical point of view also, if any patients enter into our hospital in the emergency department or in the ICU, SOB, so one of the diagnosis, differential diagnosis usually remains the heart failure. So with this, I would like to speak on the clinical approach and basics of the heart failure for all of us, the beginners and who are the nursing students and candidates over here, so that they can understand the basic pathophysiology of the heart failure. What is the heart failure? The definition of heart failure, how many types of heart failure is there, and how to approach the heart failure patients whenever you are dealing inside the ICU from the nursing point of view. That will be our topic for today. And next 30 or 45 minutes, we would like to speak on that topic so that you can understand the basic things about the heart failure, the basic pathophysiology. So with this, I am starting my topic today with all of your permission. Next slide. Okay. So by definition, the heart failure, it is a complex clinical syndrome that results from any structural or functional impairment due to the reduced ventricular filling, that is diastole, or there is a defect in the ejection of blood, that is a systole, leading to cardinal manifestation of dyspnea, fatigue, and fluid retention. As per the American College of Cardiology or American Heart Association guideline, this is the basic definition of heart failure. There is a structural or functional impairment resulting in the diastolic heart failure, or there is a systolic heart failure. So what happens on that? If the patient is having heart failure, initial presentation or manifestation is patient is having dyspnea, fatigue, or fluid retention or swelling of both the legs. So burden of heart failure in elderly in our India as well as globally, worldwide, nowadays we are seeing that as the population is increasing day by day, the burden of heart failure also increasing day by day inside the ICU as well as in the emergency department due to the prolonged longevity of the patients as well as the population. The prevalence of heart failure significantly increases with the age, 1 to 2% after the age of 40, and after the age of 50, gradually the incidence is increasing up to the 10 to 12% as per the age, and after the age of 80 years, the two senior citizens are there. As per the NIH's guideline and NIH study shows, there is a 12% people are having suffering from the heart failure after the age of 80 years. So what is the prevalence in India? The prevalence of heart failure in India is estimated to 1.3 million to 4.6 million as per Huffman et al., with annual incidence of 49,000 or more than that, 1.8 million per year. And after the heart failure has been diagnosed and established, the 5-year survival rate is following the diagnosis is about 50%. For severe heart failure, the 1-year mortality is as high as 40% as per the national guideline as well as the national data which has been published in last year in CSI conference. So now come to the basics. The heart failure, as I have been told, the heart failure is having two, basically heart failure with reduced ejection fraction or heart failure with the preserved ejection fraction. So there is a lot of things based on the classification or latest classification. The heart failure has been divided into 4 criteria. Number 1, the heart failure with reduced ejection fraction, that is the ejection fraction is less than 40%. How we can know the ejection fraction? Echocardiography is the modality of the investigation or choice to know the ejection fraction. Echo machines are available inside the all ICCU nowadays, as well as in the emergency department, and all the corporate hospital as well as the peripheral hospital. The bedside echo machines are nowadays available to know the ejection fraction. And all the students who are doing the critical care medicine as well as the nursing students who are nowadays the senior sisters and nurses, they are now also that can do the bedside echocardiography, and from that we can estimate the ejection fraction of any patient whenever we are doing the bedside echocardiography. That is the basis of any echocardiography investigations. And from the echocardiography, we can know the ejection fraction. If the ejection fraction is less than 40%, the patient is having heart failure with reduced ejection fraction. Whereas if the ejection fraction is more than 40%, or you can say more than 50%, the patient is having a preserved ejection fraction. So the second criteria is the heart failure with preserved ejection fraction, the ejection fraction more than 50%. In between these two, less than 50%, more than 40%, they are termed as the heart failure with mildly reduced ejection fraction, HF-MREF, or ejection fraction is in between 40 to 50%. The fourth variety is the heart failure with recovered ejection fraction. That means patient initially diagnosed with a reduced ejection fraction, and after that who have rapid or gradual improvement in ejection fraction following the management or medication to the normal range following the directed or guideline directed therapy. That is the fourth variety of the heart failure classification. So the number 1, ejection fraction less than 40%. Number 2, ejection fraction more than 50%. There is an in between, the ejection fraction is the mildly reduced, it is 40 to 50%, and the patient is having heart failure with recovered ejection fraction. That is the fourth criteria. So the stages of heart failure, after the diagnosis, after the definition, what are the stages, what we feel whenever we are dealing the patients in the ICCU? The stages of heart failure again divided into the 4 stages as per the ACC or AHA guideline. What are the stages? Stages are divided into again the 4 variety, the stage 1, stage 2, stage 3, stage 4, or you can say stage A, B, C and D. The stage A means the patients at risk for heart failure, stage B the pre-heart failure, stage C is the symptomatic heart failure, and stage D is the advanced heart failure. So the stage A means the patients who are high risk or at risk for the heart failure. Who are they? As per the ACC and AHA guideline, it shows the patient at risk for heart failure but without any current or previous symptoms or signs of heart failure, or patient is having any or that structural deformity. Who are the risk for this heart failure? The at-risk patients, those who are having suffering from the hypertension, patient is having a diabetes, obesity, exposure to the cardiotoxic drugs, genetic variant for the cardiomyopathy, or there is a family history of cardiomyopathy. They are at risk for the heart failure or termed as the stage A patients. Who are the stage B or pre-heart failure? Patient is having no heart failure, but there is a high possibility of the heart failure, that is a pre-heart failure. Patients without current or previous symptoms or signs of heart failure, but there is evidence of one of the following: if the patient is having any structural heart disease, if the patient is having evidence of increased filling pressure, or if the patient is having any pre-existing risk factors, they are having a stage B. Now the patient is having a stage C. Stage C means patient is having a symptomatic heart failure. These are the patients who are inside the ICU. We are dealing when the patient is inside our ICU from the nursing point or medical point of view. The patients having the current or previous symptoms and signs of heart failure, they are the stage C. So the patients who are inside the ICU, basically they are the stage C category of the patients what we are dealing with. And the next one is the stage D or the advanced heart failure. Advanced heart failure means patient is on grossly symptomatic, patient is on oxygen support, patient is on CPAP, BiPAP, or patient is on ventilator support. They are the advanced heart failure status. The marked heart failure symptoms that interfere with daily life and with current hospitalization despite attempts to optimize the goal-directed medical therapy. So from the nursing point of view or the medical point of view, whenever inside the ICU, we are dealing the patients who are in stage C or in stage D. That is symptomatic heart failure patient or advanced heart failure patients. So these are the 4 stages we are dealing in our clinical practice. Now come to the clinical features. This is the basic things we should know. What are the clinical features patient presents to us in the heart failure patients? If the patient is having a forward failure, there occurs the symptoms of reduced perfusion. What happens in reduced perfusion? There occurs decreased cardiac output. There occurs reduced blood flow to the muscles. Patient is having a volume depletion. What are the symptoms of that? Patient usually complaining of increased fatigueness. Whenever patient is walking, patient is taking or walks, or patient is having doing some exercise and these things, usually patients complains of fatigueness, or there is an increased weakness, particularly in the lower extremities. If the patient is having a coexisting cerebrovascular disease, patient is having sometimes the mental dullness, depressed affect, and confusion is also the symptoms of the presenting if the patient is having a forward failure or systolic failure. The next one is the most important, that is the backward failure, what we deals in the ICU setup. What is the backward failure? In backward failure, the most symptoms are the exertional dyspnea. Patients complaining of just like exertional dyspnea, that is patient is having a labored breathing. What is labored breathing? The labored breathing is due to the patient is having a left ventricular dysfunction. There occurs pulmonary venous congestion. There occurs transfusion of fluid into the interstitium and alveoli, decreased lung compliance, increased airway resistance, and patient developed symptom of breathlessness or exertional dyspnea. What happens on that? In the signs, what we will get inside the ICU in clinical, if we are standing besides the patient, there occurs increased access of the respiratory muscles or accessory muscles of respiration. They become hyperactive. Patient complaining of dyspnea, patient complaining of tachypnea. There may be chest congestion. There may be loud P2 if we put our stethoscope over there. If the patient is having a right-sided heart failure, what happens over there? There occurs systemic venous congestion. There occurs swelling of both the legs. Usually patient presents it with edema of the legs or swelling of both the legs. If patient is further progression these things, there may be right upper quadrant abdominal pain. There may be complaining of bloating of abdomen. What the signs we will get in the bedside? Patient may develop the raised JVP. There may be ascites. There may be hepatomegaly, splenomegaly. There is bilateral pitting edema. So this is the common symptoms or signs we are getting besides the patients whenever dealing the patients in the hospital inside. Now the pathophysiology. What happens in heart failure? The pathophysiology in the backward failure is redistribution of fluid from the abdomen and lower body into the chest after lying down. The symptoms are usually shortness of breath after patients lying down. That is called orthopnea. There occurs decreased responsiveness of respiratory center during sleep, and pulmonary congestion can compensate for increased symptomatic activity during REM sleep. There occurs shortness of breath after 2 to 3 hours of sleep onset, and patient complaining some PND, that is paroxysmal nocturnal dyspnea. So these are the 2 symptoms usually we get from the elderly patients. One is PND, or patient is having orthopnea, or patient is having a dyspnea. So these are the symptoms of heart failure in general for all the patients who are present inside the ICU or critical care setup. Now come to the basics. What are the basics of the heart failure or causes of the heart failure? Why the patients developed heart failure at the age advances? There is a lot of factors are there, but grossly there are 5-6 factors are important for the causes, and usually we deals with them every day in our clinical practice whenever we are entering inside the ICCU and these things. The common causes of the heart failure is number one cause in our Indian setup is coronary artery disease, or that is called CAD. Why there is CAD? Because most of the patients develops heart failure, coronary artery disease is patient is having either myocardial infarction, angina or angina equivalent, or patient is having arrhythmias. Second most common cause of the heart failure is the hypertension, because hypertension is one of the most common non-communicable disease and it is one of the predisposing factor of the heart failure in elderly patients. What happens over there? Heart failure with preserved systolic function, or if the patient is having a malignant hypertension, patient may present it with the acute pulmonary edema and heart failure. Third one is the valvular heart disease, as India is epitome of the rheumatic heart disease or valvular heart disease. If the patient is having a primary valve disease, patient is having aortic stenosis, patient is having a secondary valve disease or congenital valve disease, patient may develop heart failure in long run. If the patient is having various arrhythmias, patient may develop heart failure, specifically atrial arrhythmia and ventricular arrhythmia. Besides that, we are having a lot of cardiomyopathy. A cardiomyopathy, after a long run, patient develops heart failure, specifically dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy. So all these things, patient needs the specific investigations. If the patient is having coronary artery disease, invasive procedures, patient may go for the coronary angiogram or CT coronary angiogram have to be done to know the patient underlying having the coronary artery disease or not. If the patient is having hypertension, the 24 hours ambulatory blood pressure monitoring can be done. If the patient is having underlying valve disease, we can go for the echocardiography or transesophageal echocardiography. For arrhythmia detection, we can go for the 24 hours Holter monitoring. And for the cardiomyopathy, the genetic testings are nowadays available in India to know the variety of cardiomyopathy. So other causes of heart failure are storage disorder, that is glycogen storage disease or hemochromatosis. If the patient is having endomyocardial disease, specifically carcinoid, if the patient is having a pericardial disease, that is calcification infiltrative, or patient is having a metabolic disorder, specifically autoimmune disease or endocrine disease, sometimes vitamin B1 and selenium deficiency can cause the heart failure. Other causes of heart failure broadly, that is infective cause, that is viral myocarditis. After an acute viral infection, specifically the CMV viral infection, patients with dengue viral, patients sometimes develop viral myocarditis, and viral myocarditis may lead to the heart failure in acute stages. Other causes are infective, Chagas disease and Lyme disease. And sometimes nowadays we are getting the drug-induced heart failure. Patient is on different drugs, specifically the patient is having anthracyclines, patient is having a immune modulator drugs, sometimes can causes the heart failure. So these are the common things. Besides this, we are having an infiltrative cause, that is amyloidosis or sarcoidosis, or cancer may cause the heart failure in long run patients. In such cases, the different investigations are there. So we have to do accordingly, depends upon the patient's clinical presentations. So broadly, this is the picture in male and female. In male, the most common cause of heart failure is the hypertension, because in this chart we are seeing approximately 40% of the cases in the male patients, the hypertension is the most common cause of the heart failure, followed by the coronary artery disease or myocardial infarction, and third is the valvular heart disease. Whereas in the female, the most common cause of the hypertension is the number one cause of the heart failure, followed by the myocardial infarction, or later on the patient is the diabetes is another cause of the heart failure in long run in female patients. So this diagram shows the incidence and predominance of the heart failure in the male and female. In male, it is hypertension, as well as in the female, it is again the hypertension. But next, in male, it is the coronary artery disease is the predominant cause of the heart failure. Now come how you will approach to a patient in the heart failure when the patient is in front of you inside the hospital or in the ICCU. First, the most important from the medical point of view is the history taking. All the time, in the most of the time, 80 to 90% cases, if we take the history properly, minutely and meticulously, The history itself gives you the clue as well as the diagnosis for the heart failure. Because usually we are in the hurry whenever we are give the rounds and these things. So sometimes we miss some small points which may further indicates the diagnosis. So again in the clinical science, clinical cardiology, clinical medicine as well as clinical critical care, the most important aspects of any investigations is a history tracking. The proper history taking usually gives you the clue, and diagnosis is more than 90% of the cases before you reach the other modality of the investigations. So what we'll get in the history in heart failure patients, the most important is the fatigue and weakness, specifically the lower extremity. Then the important is the SOB or shortness of breath on exertion. That is again having the 4 gradings are there as per the New York Heart Association heart failure guidelines. What are the guidelines shows? The NYHA guideline that shows there is a 4 types of classification is there, 1, 2, 3, 4. As per the NYHA classification, the A1 is the patient is having a cardiac disease, but there is no symptoms. If the patient is having a mild symptoms with the ordinary activity of the SOB, that is a class 2. If the patient is having a significant limitation or activity due to the work and these things, that is class 3. If there is a severe limitation of daily activities, it is a class 4 classification or class 4 indication or grading of the NYHA grading. Next is the onset, whether the onset is acute or onset is a slowly onset. Progression, whether it is a sudden or gradual. Orthopnea, patient is having a PND. If the patient is having a swelling of legs, bloating of abdomen, if the patient is having early satiety, if the patient is having a loss of appetite, weight gain or weight loss, or urine output, we have to take the proper history one by one. And if this take the history properly, we can get some clue about the heart failure. And with the heart failure, along with the NYHA classification, we can grading them over the 1, 2, 3, 4 as from the history. Now come to the physical examination. After taking the history, just look on the patient and do some physical examination in the bedside. In general appearance, for the heart failure patient's position should be properly put, 45 degree or 65 degree, whether which position patient is comfortable, whether patient is in distress, we have to be look up in general appearance. Next one is his nutrition. Other things what we are seeing for all patients, that is pallor, patient is having any cyanosis or not. We have to look after the extremities, whether hot or cold. Then go for the heart rate and rhythm. If the patient is having an irregular rhythm, it may mightly suggest the underlying arrhythmia. Go for the pulses alternates and say whether patient is on respiratory rate, tachypneic or tachycardia. See the temperature, patient is having a low-grade fever in severe heart failure, and always look for the JBP, also look for the hepatojugular reflex. In physical examination, 3 things are important: tachypnea, tachycardia, JBP, as well as patient is having a peripheral edema or not. And lastly, the patient is having a cyanosis. So these are the things what we have to be examined in physical examination after taking the proper history. So in the respiratory system examination, because most of the patients is having SOB, that is a symptom of breathlessness. So why? We have to see the respiratory system examination before going to the cardiac. In respiratory system examination, first we have to see the respiratory rate, whether patient is tachypneic or not. If the respiratory rate is normal is around 16 to 20, if the patient respiratory rate is more than 20, it is always keep in mind patient may in the failure. Then pattern of respiration, whether the patient is having a periodic respiration or chain strokes breathing. See the shape of the chest, whether patient is having a barrel-shaped chest, because barrel-shaped chest is usually seen in the COPD patients. Any scar mark in the patient or not. Go for the percussion, you will get the dull note at the base, and in auscultation, you will get the severe crepitations at lung basis, but in severe heart failure and acute pulmonary edema, throughout the chest, you will get the crepitation, coarse creps you will get. Sometimes in chronic heart failure, you may absent the crepitations, but in most of the cases, if we put our stethoscope in the chest, we'll get the crepitations all over the chest. initial part, mild heart failure in the both of the bases, but in the severe heart failure throughout the chest, you will get the crepitations. So these are the symptoms and signs you will get in respiratory system examination in heart failure patients. Along with that, you may get the wheezing and rhonchi also. So this is the classical chest X-ray. There is a little bit of increased cardiothoracic ratio. Patient is having a pleural effusion. Patient is having a prominent Carly B lines if the patient is having a severe heart failure. Now cardiac examination, because we are dealing the cardiac patients, we are dealing the heart failure. So in cardiac examination, what we will get? The apex bit may be the displaced downward and to the left, because it may be seen in the diffuse dilated cardiomyopathy. In right ventricular heave or parasternal lift may be get in patient is having biventricular heart failure or severe right heart failure. We may get the S3 gallop or we may get the S4 gallop. Sometimes we get loud P2. Now GI examination, in appearance, we may get that there is a abdomen may be distended, position of the umbilicus may be little bit prominent, there may be abdominal venous prominence, and sometimes if the patient is having a severe heart failure, raised JBP, we may get the hepatomegaly also, and as well as ascites. So at a glance, in elderly patients with heart failure inside the ICU, this is the typical presentation of any elderly patients whenever we are seeing inside the ICU. Patient is in the bed, patient is either 45 degrees, 60 degree or 90 degree position. From the head to toe, if we see the patient from the head, what we will see? The raised JBP, there may be in chest, there may be bilateral congestion. In heart, we may get the S3 gallop. There may be hepatomegaly, splenomegaly. In pulse, there may be weak pulse, patient having ascites, and in the lower limb, there may be pitting or bilateral dependent edema usually we get. So this is the classical picture of a heart failure patient, elderly patient inside the ICU. So at a glance, if we see from the head to toe, we can see these are the pictures of a heart failure patient. So the diagnostic algorithm for the heart failure, how we'll approach the patients after the initial presentation. First, you think about whether the patient is having a suspected heart failure or not. See the patient is having any risk factors or not. Patient is having any symptoms or signs matching with the heart failure, or if the patient is having any abnormal ECG. Most important investigations inside the ICU usually we send, that is a anti-pro-BNP. If the anti-pro-BNP is more than 125, it may strongly suggestive of patient may be having a heart failure. Number one. Second investigations of choice of heart failure is inside the ICU is the bedside echocardiography. And in clinical signs, sometimes whether the patient is having any abnormal findings we are getting in hepatomegaly, JBP or that. So based on this heart failure confirmed after the initial presentation, history taking and investigations, if you are getting the heart, my diagnosis heart failure is confirmed, then you have to be measured whether the heart failure having is a reduced ejection fraction, preserved ejection fraction, or in between these. Determine the etiology and comments of the treatment depends upon the patient's heart ejection fraction. So bedside echocardiography is the one of the most important tool for us for the heart failure patients, along with the anti-pro-BNP and clinical signs and symptoms. Next. Sometimes because anti-pro-BNP is one of the most important biomarker for heart failure nowadays in clinical practice, sometimes the falsely high anti-pro-BNP we see if the patient is having with advanced stage, patient is having a cirrhosis of liver, patient is having an advanced COPD, or if the patient is having a CKD patient, sometimes the anti-pro-BNP falsely raised to below above the average level. And falsely low anti-pro-BNP usually patient is having obesity we are getting. But in general, if the anti-pro-BNP in our hospital or any hospital, there is a cutoff level or cutoff value. If the value is beyond 3 times more than the normal value, patient definitely suggestive of patient probably having the heart failure. Now come to the treatment part. How we'll treat the patient if we are dealing the patient inside the ICU. The treatment of heart failure with reduced ejection fraction. These are the patient usually admit inside the ICU because in reduced ejection fraction, the patient usually unable to maintain their own lifestyle as well as the heart rate as well as the patient's daily activity. So they usually admit inside the hospital, and initial part when they are symptomatic, they stay inside the ICU. So number one is the guideline medical directed therapy, or guideline directed medical therapy is the number one treatment of choice, that is GDMT. Our first approach should be the reduce the volume overload in symptomatic patient. The drug of choice is the diuretics. What are the diuretics? Loop diuretics. Either injection Lasix or injection torsinamide is our drug of choice. After getting the patient the symptomatic management with the loop diuretics, the next is either you have to be start 1, 2, 3, 4 or ABC, AC inhibitor, ARB or ARNI, beta blocker or MRA, and fourth is the nowadays we are using the SGLT inhibitor for the heart failure patients. So these are the basic management for the heart failure patients inside the ICU as a guideline directed medical therapy. But the first and foremost is the loop diuretics or injection Lasix or torsinamide should be given to reduce the volume overload. After the stabilization of the patient, now we can think about the interventional management in the form of cardiac resynchronization therapy or CRT or ICD implantation, or if the patient is otherwise unstable, go for the CABG or valve replacement therapy. Besides the guideline directed medical therapy or interventional therapy, we have to also think about the supportive therapy and rehabilitation. Why I have been kept this slide over here? Because this is from the nursing point of view. Because the doctor's point of view, we have to think about the guideline directed medical therapy. For the interventional cardiology point of view, we think about the interventional points. But from the nursing point of view, who are dealing the patients in the bedside every day from morning to night and every time in every shift, that is our sisters and nurse. And for them, what they have to think about the heart failure patient, what is their part? Supportive therapy and rehabilitation. And how it is? We have to think about the proper nutrition and good nutrition, correction of the iron deficiency or iron or pallor, or you can see the patient is having anemia. We have to correct that one. Fluid restriction. If the doctor instruction is given that the 1 liter fluid restriction should be there, 1.5 liter fluid restriction should be there, we have to go for the strict fluid restriction in that patient. Salt restriction, alcohol and smoking abstinence, immunization, and patient education. From the nursing point of view, or from all the sisters and these things, whenever you are deal the heart failure patients, besides supportive therapy and rehabilitation, always try to educate your patient, because patient education is the most important aspects for get rid of the heart failure or be well after the initial aspects of the heart failure. What are the few drugs available for the heart failure? That is the AC inhibitor. The AC inhibitor which is available in the market, that is the Ramipril, is the drug of choice, and followed by the Anapril and Lisinopril. Then beta blockers, cardioselective beta blockers should be used. The drug of choice nowadays, the bisoprolol, carvedilol, and metoprolol. These are the drugs usually we use inside the ICU, depends upon the patients. And MRA or mineralocorticoid receptor antagonist nowadays available, that is spironolactone or eplerenone. These drugs we are using nowadays. And as I have been told that there are two new molecules nowadays we are using for the heart failure patient. One is ARNI, that is sacubitril and valsartan combination, because the angiotensin receptor inhibitors nowadays used after the paradigm heart failure trial, and it shows there occurs 16% reduction in all-cause mortality. We use the ARNI in the early phase of the heart failure patients. And SGLT inhibitor is the new basket, which as per the ACC as well as the ESC guideline, nowadays we are using the dapagliflozin, empagliflozin in heart failure patients, because it shows DAPA-HF trial and EMPEROR trial, they both are having a good composite endpoint in cardiovascular death in heart failure patients and reduce the heart failure mortality and morbidity inside the ICU for the heart failure patients. So nowadays we are using the SGLT inhibitor as one of the important drug in heart failure patients. And lastly, the alternative vasodilators we can use hydralazine. And again, I am coming to the diuretics, because ultimately the mainstay of treatment in acute heart failure inside the ICU is the diuretics. In patients with symptomatic heart failure, it reduces the congestive symptoms. Loop diuretics is the drug of choice, and thiazide reserved for the patients with refractory volume overload. So loop diuretic is the drug of choice is acute heart failure inside the ICU, and it should be always kept in the emergency trolley or in the bedside for any heart failure patients management. These are the another novel therapies, or these are the under pipeline, how we can use these things. These are not for the. And nowadays, another drug is available in the market, that is a Finridone novel therapy. So this is in the, now we are not using in the acute cases, but diuretic is the drug of choice at this moment for us. And as I have been told, from the nursing point of view and sister point of view, the iron supplementation in heart failure is also the another aspects, because anemia itself predisposes or proposes the heart failure. So we have to correct the anemia. Iron supplementation should be given if the patient is having anemia or hemoglobin is less than 9, I think so. Because a lot of study has been done, and ESC guideline shows after the Ironman and FARM study, the iron supplementation should be given in heart failure patients. So in broadly the last slide, in heart failure patient, management of heart failure from the medical point of view, the nursing point of view, for the medical science point of view, the first drug of choice is the loop diuretics, number 1, followed by the AC inhibitor, beta blocker, AMERA, and DAPA-AMPA. If the ejection fraction is less than 35%, we can think about if the patient is ICD. If the patient is having a heart rate ejection fraction is more than 35%, patient is still symptom is persist, we can think about the CRT and other things, interventional management. So these are the things already I have been discussed. The decompensated heart failure already I have been discussed. Diagnostic workup. What are the diagnostic workup we can do in the bedside? The most and important is one is the ECG. Second is the echocardiography. One chest X-ray. Nowadays we can go for the lung ultrasound, and the blood parameters, or you can say the BNP, NT-proBNP. These are the things or biomarkers we can send to know the heart failure to rule out. So in conclusion, there are 2-3 things to say. The clinical symptoms and signs are the paramount importance in diagnosis of heart failure, especially heart failure with preserved ejection fraction. Diuretics is the mainstay of treatment in symptomatic heart failure. Other drugs can be started after the stabilization of the initial symptoms. Iron deficiency should be corrected in all heart failure patients. FCM is the drug of choice. Goal-directed medical therapy should be initiated in all heart failure patients with reduced ejection fraction or preserved ejection fractions. Patient and caregiver education and lifestyle modification is of utmost importance in management of heart failure in elderly. And here comes the role of the nursing sisters as well as students, because as you people are the caregiver, your basic knowledge and education is important about the heart failure. And if you know the basics, you can properly educate your patients and give the caregiving accordingly in bedside for the heart failure patients in the elderly. Thank you. I'm concluding my slides over there. Now handing over to my topic to our sir, Dr. Susruta sir. Susruta sir, it is on you now.
Thank you.
Yeah. Susruta sir, it is over you.
Yeah. Thank you, Jayantha. That was a nice and detailed presentation. We can take 1 or 2 questions. If anybody any questions or comments, they're most welcome. They can also put on the chat box. want to tell us anything about, do you prefer boluses of diuretics versus infusion of diuretics? Hello? Hello?
Sir.
Would you like to comment about when you prefer bolus diuretics, say 2-3 boluses of diuretics,
The initial
or
part in
infusion of
acute pain, we can
diuretics?
use the bolus diuretics, no? Because
Okay. And when do you feel comfortable with starting ARNI in a patient with reduced heart failure? I mean, how soon? After
regarding
acute decomposition?
after the initial stabilization and these things, if the patient's urine output is okay and creatinine is otherwise fine, patient is maintaining, we can start with the low dose ARNI. The initial dose is the 50 milligram BD, then we can gradually increase. So if the patient is otherwise maintaining the kidney parameters and this thing, we can start the ARNI as early as possible nowadays, after the initial stabilization with the loop diuretics.
And what do you feel should be the fluid restriction in a patient with acute heart failure?
Regarding the fluid restriction and these things, again, it depends upon the ejection fraction. If the patient's ejection fraction is less than 40% and these things, the baseline is the water intake should be less than 1.2 liter, or we can sometimes, if the patient is having a severe heart failure, the fluid restriction should be less than 1 liter. But in general, 1.2 to 1.5 liter is our initial restriction. If the patient is otherwise, the patient's ejection fraction is less than 40%.
Okay. Any other question?